Hi, everyone. Good morning, good afternoon, good evening, wherever you are. And thank you very much for joining us today. Sorry about the small delay. We had some technical issues, but now everything looks fine. Welcome to this TechNet webinar series on reaching zero-dose children. This is the very first session, and we're really happy to welcome our guest today. The topic we'll discuss is reaching zero-dose children immunization in fragile conflict-affected settings. This session is interpreted into French. I'm going to explain in French for our francophones here how to do it. Pour l'interprétation en français, vous pouvez cliquer, donc la session est interprétée en français, vous pouvez cliquer sur le globe qui est en bas de votre fenêtre, choisissez la langue, donc c'est français. Si vous avez moins de soucis techniques, n'hésitez pas à le marquer dans le chat et je vous aiderai. So interpretation is available at the bottom of the screen. Please select French. And if you have any technical issue to connect into French, please let me know in the chat. I'll try to help you as much as I can. Also, this session is recorded. The recording and the slides will be shared after the session. We'll share that by email and we'll send that to everyone who registered. Thank you very much. And I think now the floor is to Carrie. Carrie.
Great, thank you. And a warm welcome to everyone to the webinar. Thank you all for joining. And the purpose for today's webinar is to focus on solutions and opportunities for immunizing children in fragile and conflict-affected settings. So we're all aware that the progress of global immunization coverage has stalled or fallen, especially in certain contexts and geographies. Conflict is more widespread than ever before, and the greatest concentration of the most vulnerable children are those who are living in conflict settings. Unfortunately, those impacted or displaced by conflict often face barriers in accessing routine healthcare, and this includes vaccination. WHO estimates that approximately 20 million children do not receive basic childhood vaccines every year, and around 40% of these children are those living in fragile states or those that are partially or entirely affected by conflict. While fragile or conflict contexts are not always the same, there are some commonalities and critical challenges blocking immunization services from reaching children in these areas. These include issues such as either targeted or incidental damage to health facility infrastructure. There is often lack of delivery of services amidst insecurity, and this also impacts vaccine supply chain. Often there is challenge in retaining or ensuring the safety of health workers in these areas, creating an inadequate human resource to provide healthcare to people in these areas. And there can be mistrust between authorities and communities, and often it leads to blocking access of people and services that are perceived to be against the communities. And sometimes there is significant population movement, either from displacement or migration in these areas. Children in these settings are the most vulnerable to disease outbreaks like measles and polio, which can cause death or lifelong disability. And these could have been prevented if all the children were provided an equitable opportunity to be fully vaccinated. Whilst challenges of providing immunization in conflict settings are significant, there are some best practices in addressing the issues of access and utilization of services in fragile states that are worth replicating or building upon and scaled up to impact coverage. So we'll have our speakers today. Our first speaker will be Sara Al-Dahir, who will present a case study on immunization rates during periods of conflict and recovery in Anbar region of Iraq. Our second presenter is Enrique Paz, who will be speaking on the topic of health resilience in fragile settings, where establishing resilient health systems is significantly important to withstand the initial shocks from conflict and for longer term recovery. Then we'll hear from our third presenter, June Ajuku, on the immunization and resilience efforts that are ongoing in the fragile country of South Sudan, which continues to be a country with a very high percentage of unimmunized children. So now I will turn it over to our first speaker, Sara, to start us off. Thanks.
Thank you, Carrie, for that introduction, and thank you for the opportunity to present my research. You could go to the next slide. Fred? I'm a professor at Xavier University, clinically trained as a pharmacist and research trained as an epidemiologist. And I'm going to be presenting the results of a 2-year study that occurred that covered a 6-year period in Anbar region of Iraq. Next slide, please. I'd like to thank my research team from Johns Hopkins University, Dr. Moss, Talat, Dr. Knoll, and Dr. Burnham, and of course, the Iraqi research team of Dr. Hassan and Dr. Khalil. Next slide. This study was conducted. You can go to the next slide, please. Yeah, so this study was conducted to look at what were the predictors of lack of immunization completion by 12 months of age. We used the standard mixed definition of immunization completion of the primary 6 antigens, looking at polio, DTP, as well as measles. And we wanted to look not only at factors that are traditional in the UNICEF mixed coverage data, which looks at demographic variables such as maternal and household variables, but we really honed in on those predictors associated with conflict. We looked at internal displacement, home damage, food insecurity, housing insecurity, and we looked at not only the 6 antigens of the primary immunization schedule, but we also looked at the additional coverage with regards to rotavirus and pneumococcal vaccine. Really, this research was used to inform sustainable intervention strategies, not only for children in the midst of conflict, but also protracted recovery periods. You could go to the next slide. So as a background, we'll go ahead and look at the history of Iraq, which everyone is familiar with. The next slide. So the immunization program, the EPI program in Iraq, was established in 1986 and was extremely successful and extremely robust. But that has subsequently been followed by 30 years of unrest and warfare, as well as invasions. There was a precipitous drop in immunization coverage after the first Gulf War, and that continued under the sanctions that occurred nearly for a decade. There was a time of recovery when the Oil for Food program was reinstituted in Iraq, but that was quickly set back by the second Gulf War, followed by 5 years of sectarian violence. And then there is a 3 to 4 year period in which ISIS invaded and occupied large regions of Iraq, Anbar being one of them. This study actually was started during the 2019 mass protests in Iraq, and we were able to continually to successfully continue this study in the midst of the COVID pandemic. But what we're going to be focusing on is all those experiences prior to the COVID pandemic. Next slide. So where is Anbar? Well, Anbar borders Syria and Jordan, as everyone recall. ISIS had a very strong presence, particularly in Syria, and they occupied a large portion of the Anbar province. The area that we're focusing on is Haditha. Haditha is directly below the Haditha Dam and is a major hydroelectric source for Iraq, but is also a desirous point of occupation. And therefore, ISIS occupied Haditha, but the Haditha metropolitan and suburban area was strangulated or surrounded by ISIS, whereas the more rural areas were actually occupied by ISIS. So we have 2 different experiences with regards to children in conflict. We have those who are directly under occupation forces, particularly this was ISIS, but we also have the experience of those children who were deprived of services despite Iraq's very aggressive attempts to continue to provide immunization and food to Haditha, but the area around Haditha, particularly the blue dots along the river, were strangulated by ISIS, preventing the inflow of medications and vaccines as well as food. And the healthcare workers during this time describe an average 20-kilo weight loss during this period, and a lot of this, of course, violence and unrest during this 3 to 4 years of occupation. The next slide, please. So what information did we have before going into the study? Well, we looked at mixed coverage, and we looked, of course, at the joint reporting format. And you notice we have some information directly after the sectarian violence of 2010. And Ambar, when we look at the 3 antigens, we have about 63% coverage. Directly after the ISIS occupation, we have 40% coverage. And if you look at the fully immunized child, as in children who are able to receive all the necessary primary antigens prior to the age of 15 months, that coverage is 27% of the children in Ambar were completely immunized on time prior to 15 months of age. Within Haditha specifically, the measles coverage was shored up by very aggressive measles immunization campaigns, but as everyone can tell, 82% is insufficient to reach herd immunity. So measles has returned to endemic levels in that region. Next slide. So if we look at the next slide, we built our conceptual model for this study, and we embedded it in the traditional mix demographic variables for prediction. But then we also looked at health resilience variables, as in what was the health system able to do to not only maintain, but have some aspects of recovery in the post-conflict period. And then we also looked at the experience of conflict specifically. So if we could go to the next slide. So our study population, next slide. Iraq has a very robust birth registry, and the birth doses are given in conjunction with the birth certificate, and they have excellent birth registration information. And within the Haditha Ministry of Health and the District of Health records, they also keep in parallel to the birth registry a list of children that we would call lost to clinical follow-up. These are children at any time in the 6-year immunization schedule that fell out of the immunization schedule and then did not return to the schedule. So we have about 16 to 17,000 children that are registered in this schedule, and total there's 4,000 children who are termed the mutasarribin, or children who are lost to clinical follow-up. Now, these are not just children who fell out in the 1-year schedule. They could have fallen out all the way up through the 6-year schedule. Next slide. So from this list, you can go to the next slide. From the mutasarribin list, it includes all those individuals who are not only surrounded by ISIS, such as like occurred in Fallujah and Ramadi, it also has those children that were occupied by ISIS. So the children from the 2014 to 2017 cohort are the conflict children, but we also compared them to the children that were born in the 2018 to 2020 cohort, who are the post-conflict children. At that time, 3 of the PHCs were only 50% functional as of 2019. You could go to the next slide. So how did we sample? We took this list and we randomly sampled 450 households, and we only chose 1 child per household to get their immunization information from. It represented about 1,450 children total. We, of course, followed all COVID-19 health protocols, and we coupled our study with outreach for catching children up on the immunization schedule. So here we have Mr. Mohammed providing immunizations while doing the study. Next slide. You could go to the next slide, please. Okay, so we use a chi-square analysis. We also looked to see what were the most significant predictors, but we also wanted to see, when do these children fall out of the immunization schedule? Was it 2, 4, 6, or 12 months? So next slide, please. And so here are our primary results. And go to the next slide, and you could actually go to the one subsequent to that where I have it highlighted. Oh, sorry, hold on this slide for 1 second. So what do we find different? We found children that were in the conflict versus the post-conflict cohort, that the main issue that the parents reported is that the vaccine wasn't available. But 84% of the parents reported they simply were not able to bring their children to vaccination appointments due to conflict. Interestingly, in the post-conflict cohort, which is 2018 to 2020, about 27% of those parents also said ongoing particularly ISIS-related violence that was occurring even in the recovery period also prevented them from getting immunizations for their children. Next slide. What was their experience? 28% were displaced, 66% were surrounded versus occupied by ISIS, and nearly 80% said difficulty across the board for food and healthcare access. We go to the next slide. So what came, and you could go to the next slide as well to where it's highlighted. So what did we find? We found that the experience of being born in a conflict cohort, those children were half as likely to be fully immunized compared to those in the post-conflict cohort. Interesting though, children who were born under in the ISIS occupied territory versus the ISIS strangulated territory were 1.7 times as likely to have their immunizations completed. That is because ISIS did set up a parallel health delivery system, in which it brought in healthcare resources, which they did, of course, do for a fee-for-service approach as opposed to Iraq's Ministry of Health approach, which of course is free immunizations. And we found that a lot of them were the children in the conflict cohort were unable to get vaccines because they simply were not available. Next slide. When did the children fall out? Well, half of the children fell out after the birth dose. So these are children who were born between 2014 and 2017, and they were gone from the immunization schedule anywhere between 3 to 5 years, and they did not re-enter the immunization schedule. You could go to the next slide. And it wasn't simply the primary antigens, it was also rotavirus, so 75% were missing, and the pneumococcal vaccine, 92% were missing. MMR, 30% reported being missing versus 45%. That is largely due to home-based aggressive campaigns on the part of the District of Health. The next slide, please. So what is the public health impact? The next slide. So if we do some modeling, we find, and we extrapolate it to all the children in the Haditha district, which represents around 23,000 children, we have 13% were under immunized, 10% would be, according to Gavi, under immunized missing DTP3, and 3% would be defined as zero-dose children. Nearly 800 children would be defined as zero-dose children. A small percent, 44%, are true zero-dose, as in they were actually missing their birth doses as well. Next slide, please. You go. Yeah. So what we're hoping, even though Iraq, and if you look at the national trend information, that there's been wonderful improvements in childhood mortality since 2006, but within an area with as many resources that Iraq has had, not only due to persistent and continuous conflict, but there's pockets of children that are vulnerable throughout the recovery districts. And these children continue to be vulnerable. And even though 3 years had elapsed, the health infrastructure had not been able to recover sufficiently to reach these children and reintroduce them into the healthcare system, with lack of vaccines being the primary reason. One of the limitations of this study is that we did have to conduct most of it during the COVID pandemic. And next slide. I want to thank Xavier University for their support, as well as, of course, a lot of this was done under the excellent work that UNICEF has already been conducting, and the mentorship from Johns Hopkins University. Funding was from Gulf Medical Relief Fund. Thank you for this opportunity to present these results and engage in the discussion to help not only children in conflict, but even those in the post-conflict period to re-enter their immunization schedules.
And next question from Abdu. What are the challenges of implementing development activities while developing humanitarian actions, meaning the crisis is not yet over? Someone would like to take this one? Maybe I repeat it, just in case it was too fast. What are the challenges of implementing development activities while developing humanitarian actions?
Yeah, I mean, Sara can do it, or I can do it. I don't know.
Well, I think the difficulty is to speak from the experience of Iraq, and I'm trying to answer some of the questions in the Q&A as well. In Iraq, it is unique in that there's been, you know, opportunities for recovery and then conflict and recovery. And so the 3 decades of that. So it'd be difficult in a place such as Iraq or other areas of the Middle East to say that this is what would be optimized in conflict. What the healthcare workers in Iraq have said is that they need to couple those opportunities during recovery with planning for the next conflict. So when there are waning periods of peace, which hopefully will be sustained, that we need to be aggressive on the fore end with regards to creating those kind of collateral health system structures that would provide opportunities to reach particularly these isolated groups should another conflict come. And this might be a lesson for other areas of the world as well. And I might let Enrique respond to that, given his experiences as well.